Okay, first we're going to look at an active range of motion assessment of the patient's shoulders. So first I'm going to ask you to take off your shirt for me. Thank you. And with all of our motions, what we're going to do is we're going to have the patient stand up nice and tall, shoulders back, nice and tall. And we're going to go through, and you're going to go through a motion until you first feel pain, and then bring it back to neutral, and then we're going to do the same thing, going as high as you possibly can. So first what I'm going to have you do is take your arm, and I'm going to have you bring it up in front of you as high as you can, and stop when you start to feel pain. Okay, good. And then you're going to bring it back down. And do the same thing, trying to go as high as you can. Okay, good. And we would have them compare back down to the other side. Then we're going to do abduction. So what I'm going to have you do is bring your arm out to the side up until that first point of pain. Good. And then back down. And then you're going to do the same thing all the way up. And we're assessing, does it feel tight at the end? Is it pain that's stopping it? Or is it more of like a sharp pain? What kind of symptoms are they feeling that's limiting their motion? Next, I'm going to have you bring your arm back behind you as far as you can. Good. And then remember, stay nice and tall the whole time. Good. And repeat again. As far as you can. Get a little bit more motion. Next, we're going to do, I'm going to have you bring your arm across your body, stopping when you first feel that pain. Good. And then back down. And then we're going to do the same thing as far as you can, seeing if there's any difference between pain or tightness or the end feel, what that feels like. Good. Next, I'm going to have you bring your arm up. And you're going to bring it back as far as you can. Good. And then back down. And so pain was limiting you on that one, so I want you to do it again. Back as far as you can, even moving through that pain a little bit. Good. And then back. Then you're going to do the opposite. You're going to bring your arm down. Good. And then as far as you can. Good. And you can see he starts to compensate and roll forward on that one. So that's just a general active range of motion assessment. Ways that you can kind of differentiate between thoracic and cervical is I'm going to say, okay, I'm going to have you slump all the way down this time and look down. And then, for example, for flexion, I'm going to have you bring your arm forward again from this position. So you can definitely see that there's something limiting, but you can also see if there's a difference in the pain, taking that thoracic and cervical spine out, and then just depending on the arm. Okay, same idea, but I'm going to have you stick your chin out for me. Good, and then bring your arm up forward again. Any difference in your symptoms, asking about those kinds of things. Another thing you can do is if you're going up to the side or you want to make sure it's not a muscle issue, you can have them bring their ear towards their shoulder and then go through the motion and see if there's any change in their symptoms. So kind of bring that arm up to the side again. Good. And then back down. So you can see there's definitely a difference there. So you would ask about the pain and then the symptoms. The only other thing you do, I'm going to have you turn to the side, is you can check out the shoulder blade as it's moving. So he's a little bit anteriorly tilted, so I'm going to have him stand up as tall as he can. And then what I'm going to do is kind of add a little pressure, stabilize that into a little bit more of a posterior tilt, and then have him repeat that forward, reaching right in front of you again like you did before. Good. And then back down. Help stabilize it, or you can also kind of help assist the motion by gliding it into a bit of an up. All right, we're also going to look at combined motions. So what I'm going to have the patient do is reach behind their back and then up as high as they can. It combines a little bit of extension, internal rotation, and adduction. And you can do a good marker of where on the spine one arm reaches versus the other. And you can also even do a little bit of overpressure at that point, just lifting that arm a little bit further. The next one I'm going to have you do is up and over your head. That's a little more external rotation. And same idea, you can kind of bring a little extra overpressure if that's not painful. It gives you a good functional comparison between the two sides. Okay, we're going to look at the capsule stability, and we're going to compare both sides. So what I'm going to have to do is have my patient sit up nice and tall and relax. And to first assess the superior portion of the capsule, we're going to get right on the top of that end of the acromion, right where you kind of feel a little bit of a divot between the glenohumeral head. And then you're going to stabilize on top of that. And then I'm going to take my hand at their elbow, and I'm just going to pull straight down. And what we're looking for, and you can even kind of put your little finger on there, is to feel how much of a motion there is and if there's any reproduction of pain. You might also see a little bit of a divot, and that's the superior sulcus sign, and you can compare each side. You can also do a bit of a load and shift to look at the anterior, posterior, and then inferior portion of the capsule. So what I'm going to do is, again, I'm going to stabilize around that scapula and over the clavicle, and then my other hand is going to be on the humeral head. And what I'm going to do is I'm going to apply a bit of an anterior force, kind of a glide, just assessing that mobility. You can also apply a bit of a posterior force glide, assess that mobility, and then even a bit of an inferior, although the best way to do that is actually to have the patient in 90 degrees of elevation. Again, stabilizing, get your hand on there, and then just assess. All right, next we're going to do an overpressure assessment of the patient. So we're going to have them laying down, and then fully relax as much as I can. So first reflection, I'm going to bring him up as high as I can, supporting that arm, and do a passive assessment. And then I'm going to do the same thing when I get to that end range. I'm going to provide a little bit of overpressure and checking for pain, change in symptoms. Same thing in the abduction plane. I'm going to bring his arm up as high as I feel like it kind of can go passively, checking for pain, reproduction. And then you're going to do the same thing at that end range. You're going to apply a little bit of overpressure. Again, I'm going to have him reach across his body as far as I feel like I can, and then a little bit of overpressure checking for pain. Next, we're going to do internal and external rotation, kind of supporting that upper arm so they can stay nice and relaxed, 90 degrees, and then we're going to come in to the end range, and then you can provide a little bit of overpressure. And then you're going to switch your body, same thing, supporting that upper arm, coming down, and then a little bit of overpressure. If that's an uncomfortable position, you don't have to bring them all the way up to 90. You can do the same assessment at a less abduction. Finally, I'm going to have them scoot towards the side as far as you can. So your arms off the bed a little bit. Good. And then we're going to come into extension as much as we can, and then a little overpressure. You'll see that. All right, to assess the different joint mobility, first we're going to start with glenohumeral joint mobility and glides. So what I'm going to do is I'm going to get the patient in a bit of a comfortable position, just kind of loose pack at first to assess, and I'm going to do a anterior-posterior glide. Now this is theoretically good for internal rotation, although the science is pretty similar, says that the results are great for external and internal rotation, so it doesn't really end up mattering. What I'm going to do is come off of the edge of the clavicle until I'm truly over the glenohumeral joint. Actually, I'm going to have my patient scoot to the edge a little bit so that, yeah, he's off. So I'm not running into the table before I'm running into the end of their motion. And again, just kind of supporting with my leg, my arm. First, I'm going to just do some gentle grade 1, grade 2 glides just to assess how we're doing. And then we're going to get into more of that end range resistance for grades 3 and 4. If they are restricted in motion, same idea, except we're going to do those grade 3 or 4 glides, and we're going to do more at the end of their motion. So you can just kind of see the difference. For inferior glides, normally I would hold about like this, but that's going to block your guys' view. So what I'm going to do is just support like this. That's not normally how I do it in the clinic. Same idea, step off of that clavicle right over the edge of the glenohumeral joint, and then provide that inferior glide. You're going to start pretty gentle into the range at first for pain, and then move grade 3 and then 4. Same idea, because this is good for flexion and abduction, is you can move more into the end of range and provide that glide. We can also do an AC joint assessment from here, and the AC joint, the anterior posterior glide is typically what happens with protraction of your scapula. What you're going to do is you're going to come up to the top of that clavicle. I like to use the fatty part of my thumb, get right over it because it's a little uncomfortable, and then get my body weight over it, and you're just going to give that gentle anterior posterior force. You can also kind of assess posterior to anterior since it's not that big of a joint, or you can do that same idea but in prone. Finally, we've got the SC joint. So I'm going to have my patient scoot over just a little so he's not, feels like he's falling off. I like to do thumb on top of thumb because it can be a little bit of an uncomfortable joint. Right at the end of the collarbone, that right near the sternal border. And for inferior glide, you're assessing for overhead motion. So what I'm going to do is going to get it right over that edge. It's a little ticklish. And you're just going to provide that inferior force and assessing each side and comparing. Another one you can do is more the posterior force.